So now it's a few minutes after 8 Swedish time. I want to say welcome to all of you to this great event. And today's topic about patient data. My name is Stefan Göthberg, and I'm running the GREAT as a networking community in the west of Sweden. So I will just have a short introduction about the what GREAT is, and then we will, of course, as quick as possible, move over to today's topic. And we will be quite many in the meeting, so please stay on mute if you're not going to speak, and I will try to facilitate for us to move forward. So, GREAT. It's a networking organization focused on developing IT infrastructure in West Sweden, and we were founded in 2004. So we have a lot of years, a lot of exciting years since then, and but we are still working with our main topic, the infrastructure, and what it can give. Of course, now we're not talking so much about cables anymore. We are talking about how to use the infrastructure that we now have compared to 2004. Our mission is to work for the development of a digital society, innovation, and quality of life for both individuals, of course, companies, and other organizations. It's about 50 members, and our main task during a year is to host seminars like this, and before 2020 we of course had seminars also in physical meetings, so hopefully we will come back to that quite soon. Among our members there are companies, of course. The main part is companies, but also universities, telecom operators, and others with the same interest in digital infrastructure, and we are gathered to make sure that the Gothenburg region or west of Sweden will continue to be in world class when it comes to infrastructure to the digital world. We working in 3 different perspectives, you can say, and there are responsible people for each and every one. Today we will look into the health tech track, of course, but we also have seminars covering the infrastructure questions, but also and the third one is about the Internet of Things, and that can be anything, any topic that is depending on the infrastructure. So, but today we will focus, of course, on health tech, but also, of course, coming to the Internet of Things. So we are running, as I said, events focusing on IT infrastructure, Internet of Things, or health tech. So please, on our website we'll publish all the coming events as well after this that we will have this morning. So let's come into today's topic, the patient data as a tool, and we will have a really exciting speakers today, both from Helsinki University Hospital. It's Mikko Rotonen from Helsinki, and also Joona Pylkes from Tieto will be a part of the first part of the presentation. Then we will hear from Marcus Lingman from region Halland, and in the end, we will summer this hopefully with the panel discussion where also Helene Seeman-Lodding and Mats Sundgren will join together with the speakers, and it will be moderated by Mia. So I think this will be a really exciting morning. So if once again, if you're not speaking, please be on mute. And if you want to put questions to the speakers or to the panel in the end, please use the chat session in Zoom too, and then we will capture that. So Mia will be able to share that. So okay, let's hand over to you, Mia.
Thank you, Stefan. And so my name is Mia Ekdahl, and I am head of communications at Sahlgrenska Science Park, and also a member of Great Health Tech. And it's a pleasure to moderate this session today. I believe that one of our speakers have had a few issues joining. So my question is, has Mikko been able to join yet? Because otherwise I propose that we make a short swap in the order and start with Marcus Lingman instead. So Mikko and Jona, are you Jona, you know better, so a quick question for you, Jona. With that, I think that probably solves the question. So Marcus, if you are ready to go, if I could ask you to start instead, if that's not an issue.
Sure, no problem.
Okay, so the floor is you. Marcus Lingman is probably known to a lot of you, and we're really pleased to have you on board, Marcus. The AI Swede of the Year, as it was, but I think there are much more stories to be told from you, and it's a pleasure to have you here. The floor is yours.
Thank you for inviting me back to GREAT. I was actually here, I believe, a couple of years ago, speaking about the story we are in and have been through, and it's super exciting to be back and tell you a bit more about what has happened since. But I believe there is some new audience as well, so I will summarize the older part of the story and take it from there first. So let me share my screen. I prepared a few slides for this purpose, and hopefully you can see them now. Thank you, and I will put it in the presentation mode. So Marcus Lingman, I'm from Region Halland, and my position right now is Chief Strategy Officer at the Halland Hospital Group. So I'm on the board full time, which includes Halmstad and Varberg and Kungsbacka Hospital, 2 acute care hospitals and 1 elective hospital. I'm also the adjunct professor of medicine and information-driven healthcare at our university, and I'm also affiliated at the Sahlgrenska Academy. So I'm a physician and cardiologist by profession. So where do we start? Well, we know that we are running a fairly complex and large healthcare system that is supposed to deliver health and longevity. That's the purpose for us going to work every day. We are at 8,000 employees, so we're a fairly big organization. And what we know is that when we act in a non-cohesive, non-comprehensive way, that is a fragmented way, the population, the individuals we're set to serve, don't fare as well. So connected care, integrated care delivers better than fragmented care, both in terms of efficiency, but also in terms of patient safety and basically all other measures that you can come up with. In this case, in the group of patients with atrial fibrillation, a heart rhythm disease, where mortality can be reduced by half only by switching from a fragmented care into a well cohesive care. So this topic is important. The challenge today is that the ecosystem of healthcare is increasingly fragmented. So by ecosystem, I mean all parts of your everyday life, but also healthcare that contributes to your health and longevity. And all these things, these parts, these fragments of the ecosystem continuously generate information in large amounts and in stored as certainly data. So this is healthcare is becoming an information handling problem. And it's pushed even further by the fact that the amount of information is increasingly going beyond all borders, actually, when now we're diving into precision medicine, where we map our genomes, our proteomes, our metabolomes, like all the molecules in our human bodies. So, and this is vast amounts of information. So we both have the administrative information, the data from the healthcare system, the EHRs, etc., and the biological data, which is almost impossible to grasp for a human mind. So the conclusion already, well, made by us in 2014, but also in national reports today, is that we don't have control of our healthcare systems. We can actually not understand how well they provide health and longevity, and we cannot understand how efficient we are or how not efficient we are. And this is a scary insight, but it's unfortunately more true than false. So what we've been working on in the region of Hallands since 2014 is actually towards this goal, which we now call information-driven care. Information is, as in many other sectors, the gasoline of the healthcare, and basically what we do in healthcare is use information to guide our decisions. And we usually speak about it in terms of working along the value chain of knowledge. So we start with the data. The data is certainly dumb, but it's huge, and we try to translate it into information, but that's not enough. So we need to take it further into insights. That's not enough. So we need to alter our behavior based on the insights in order to create patient values. And all these steps have different demands. So in the data to information step, for example, you have the business intelligence capabilities and also the artificial intelligence toolbox. But that's only part of the knowledge journey, certainly. But what we want to achieve with this way of thinking is actually precision healthcare, going from group-based or guidelines-based healthcare into individualized healthcare for real, based on data, based on predictions for you personally, and not for you as a patient part of a group. So that's the notion. In order to do this, we in 2015 we built our data warehouse. And this was the foundation of everything we have done since. And we did this together with a team you see at the bottom of the screen, Harvard Medical School, Harvard Business School, and also with support from MIT in Boston or Cambridge. And the idea here, and this is what we have been using now for the last 5 years, is to combine all aspects of care, all parts of the healthcare chains, so that we can track patients across the healthcare system from all perspectives: resource utilization, clinical data, provider data, etc., all at once. And when you have these capabilities and you put some software directly on that warehouse and provide processing power, etc., GPUs, then you can do variability analysis and adequate return on investment analysis that we were not able to do before, and few other healthcare systems across Sweden and unfortunately few across the world are capable of doing. But you can also apply machine learning methodologies for the very complex data amounts that we store. So this is the basic. And we did this work in a very thoughtful manner, we think, or we were lucky maybe, but we did it from the patient's perspective. So we built our data warehouse based on single individual patients that you can aggregate, but you don't need to. And we connected all the data pieces from all kinds of software, EHR, financial systems, etc., even GeoIDs, to the individual, so that we can follow them. If you're a clinician on the individual level, if you're a manager and responsible of resource utilization on an aggregated level, depending on what granularity you need. But we also developed a way to describe resource utilization across borders on the individual level in order to get away from budget steering or budget confinement on departmental level, as used to be the case. So we developed together with Robert Kaplan and his team at Harvard Business School what we call patient encounter costing, which tracks on the individual level resource utilization across the whole healthcare system. And we also prepared the data layer with the analytical tools used by both researchers and our analytical team in-house, like MATLAB, R, SAS, and SPSS, etc., but also just normal dashboards to facilitate the understanding of the data. And in order to do this, we built what we call the Center for Information-Driven Care. So at the regional level, connected directly to our CEO, the healthcare director, we have an agile team. It's not a department, it's not an office, it's like a team of very, very disparate professions and competences and skills that work together to take data into information and further into insights to guide altered activities to provide better care. So we have chief medical officers, we have R&D people, we have data analysts and HR people and all kinds of people that are connected to the analytics in order to get this comprehensive view of our situation. And we do this not by following up stuff, but monitoring and looking forward. So many companies, they follow up, they understand, they see what has happened, and then they make decision based on that historic information. But that is actually backing into the future. So we now monitor our healthcare system in total from all these kind of perspectives, and we do prospective analytics on the same data, basing our many of our decisions on what is going to happen with a certain degree of certainty instead of following up. And we do this in a very, very agile way. We call it jam sessions. So we gather the people that we need, and that might be the clinicians, the top managers, and the finance people, whomever is needed for getting forward. And we join around the data in real time. And we do analytics in real time. It's prepared, certainly to a certain degree, but we can also answer questions at the sitting table. And the goal, and we do this in a structured way on the right of the screen, so that we can get out of that room without further need of investigation or anything. We make decisions at the table, and then we go out and do and monitor. And in terms of reaching higher efficiency across a healthcare system, it's important to understand where you have your resource-intensive venues. We need to deliver care where the resource utilization is the lowest while achieving the highest quality and outcome for our patients. And that is often not in a hospital bed, because that's one of the most resource-intensive healthcare venues we have across the healthcare system. So that's where we don't want the patients to need to be. So that's why we, in a care chain, this is an acute care chain from left to right, going from the home and increasingly escalating the resource utilization. We systematically move activities to lower resource utilization venues, which is very, very successful. We have Sweden's most efficient healthcare system today, and we have Sweden's best access to care and Sweden's best, most content population in terms of how they see their healthcare system. We can also understand the magnitude of different interventions. So we, as I said, we use this new kind of health economy methodology, and we use it both for academic purposes, publishing what we do, and also in-house analytics. This is one of the published papers that where we describe that if you follow guidelines for congestive heart failure patients in this case, even though the pharmaceuticals cost us money, the total cost of this population in terms of healthcare utilization from all aspects is much, much lower if you adhere to guidelines, even though the interventions in the guidelines cost us money. So, and it's very, very hard to do this kind of full analytics if you don't have insight in all aspects at once. Many analysts look at one thing at the time, the resource utilization or the quality or the waiting times or whatever, but you need, in order to make good decisions, you need to take all aspects into account at a certain given moment. We also do, as I said, more advanced analytics directly on our healthcare data inside the region. For example, predicting on the individual level who will be readmitted to the healthcare to a hospital bed within 30 days, because that's something that national authorities measure and we report. So we develop AI models to understand who is at risk of being readmitted to the hospital within 30 days after discharge. And that's and the area under the curve, the accuracy of that model is 94.94. So it's the accuracy is very high, and that's also goes for another model that we published, which is on mortality after an ED visit, where you seek acute care, you go home, and we want to make sure that you're safe when you're going home. These predictive models can help us make sure that you will fare well after being in the emergency department with a high accuracy. We got a very good funding from Vinnova to support this this work. So we drive together with Sahlgrenska and with AI Sweden, where I'm also affiliated, one of the 5 innovation environments that is actually also called information-driven healthcare in Sweden. And what's important in this session is to understand that no single entity, no company, no healthcare system, no provider, no researcher has all the components needed to make real progress. Either you have the competence, but you don't have the data, or you have the data, but you don't have the meaningful goal, or you have the data and the competence, but you don't have the money. So you need all these components in order to succeed, and I think we have a good setting for that right now. We are
Marcus, sorry, it's Mia here. I just want to ask, you have we're running a little bit over time, so just
and this is almost my last slide, so sorry. So we're building further on this ecosystem with more researchers and companies. We're working on natural language processing to utilize our unstructured data, which is a lot. And what we're trying to reach is, as I said, predictive precision healthcare on the individual level using information-driven care. And actually, there's a book that came out on this topic that we wrote last week. So thank you.
Thank you so much, Marcus. A really interesting presentation and lots of questions, I'm sure. So I have one quick question for you here, but I would also like to ask everyone who's listening in, if you have questions for Marcus or any other speaker for that matter, or for the panel at the end, please write them in the chat function and we will come to those later in the program. But one question, Marcus, given the relatively recent publication and how you can prove that if you just follow the guidelines, you will save money. Have guideline groups come back to you, looking to these models, because that's of course a great resource for them to ensure and implement guidelines?
Not very many guideline groups actually, but many companies are interested in the complete healthcare utilization and the resources that are driven in order to understand different products' place in the healthcare chains. So there is quite a few projects going on this topic, but the healthcare aspect, the healthcare economy aspect of guidelines is rarely actually considered when you write non-Swedish guidelines on the European level, for example. But in the kunskapsstyrning, which I'm in the national kunskapsstyrning organization, it will be required when we go forward to describe how your new guideline will affect total healthcare utilization across the system.
Thank you so much. To make sure we have time at the end for a longer panel discussion, I will come back to you later on, Marcus. And with that, I would like to introduce our Finnish friends who will tell us about how the Helsingfors University Hospital and the Helsingfors region has used data. So with that, I do believe, Mikko, that we now have you with us on the line. Is that correct? Mikko, are you there? You might be on mute. If not, then instead I would like to introduce Jona. And Jona, are you with us on the line?
Yes, I'm here. Morning.
Okay, good morning. So Jona Pilkas works at Tietoevry and has worked very closely with the Helsingfors University Hospital and the region. Why don't you introduce also Mikko in case we have Mikko on the line in a few seconds, and you can tell us how you work together, and the floor is yours.
Yeah, morning. I'm Joona Pylkäs from Tietoevry. I'm the head of our data and AI unit, and we work together closely with the Helsingfors University hospitals and other hospitals or healthcare service providers in the Nordics. And Mikko Ratonen from HUS, he's responsible for the ICT and IT development as a director of that area in the HUS organization. And the relationship between us, Tietoevry as a company, and HUS as a customer has been ongoing in this data and analytics area since 2016, when we started to build this and co-develop this data lake and data-driven solutions for healthcare. So let's see, I will start sharing now. I think Mikko is still unable to speak. All right, I hope you can see the presentation.
Looks fine.
So today I will talk about the HUS data platform, data lake, and the high security analytics workspace and platforms that we have recently built on top of it. The idea of this presentation is to give you information how to build and implement a high security and compliant healthcare data platform to a hyperscale public cloud environment. So a few words about HUS. HUS is responsible for as a secondary care unit for mostly of 40% of the Finnish population, over 2 million patients there. And as you can see from the figures, that is a quite a large scale operation. So a lot of specialized surgery and some procedures are consolidated to HUS on the national level. So if we move more on the data area and information area, this is the current setup in HUS, and which is quite a large scale environment for the data management and logistics and development. So if we start from the left hand side, those are some of the data sources. So we have different EHR solutions like Epic that is now used in HUS, but also other patient record information systems in the area, also in primary care. Then there's diagnostics like radiology lab, pathology, and genomics. And we also have all sorts of signal data, biosignal data coming from the ICU devices and other medical devices as a streaming data. Then we have also patient-generated data coming in from the Health Village, which is an e-health service portal for the citizens and patients. And also we have a lot of non-clinical data coming to the data platform, meaning finance and other administrative systems and HR solutions. And all of these, or most of these data sources are integrated to the data lake with the automated data pipelines. So maybe once a day or continuously, like real-time data is being transferred to the data lake through different kind of technical integrations. And then we have the data lake side and data platform side, which is divided to these different categories or zones. And the raw data, yeah, that contains all of the data in the raw format. And then we remodel it, transform it, and if there's some quality issues in the data, those are being fixed while the data is being moved to this master data zone. And from there, we can even further refine the data. And for example, we can automatically transform the proprietary data format to OMOP common data model or FHIR common data model, and make it more standardized. Once the data is in a format that matches a business need and business case, then it can be distributed to these different use cases. Again, there's like 4 different categories here. So the data is being used for research purposes, so mainly medical research, then for clinical operations, meaning applications that are provided for the doctors, and then for other kind of operational data, operational uses, dashboards and stuff like that. And then you have the self-service analytics and the reporting. And there, I need to just move a bit on the window. Yeah, and then on the application side, on top of the platform, we have all sorts of tooling available, from Power BI to machine learning tools, and all sorts of different also developed applications. And then one of the newest components that have been added on top of this platform is this high security data and analytics platform and workspace. And I will talk about this a bit more next. So just some figures here on the data lake from a data volume and format size. So we have a lot of data, hundreds of millions of lab tests and lots of other structured information from the EMR and unstructured free text, but also image documents and signal data. Like this is an example for the cancer data that if you want to do advanced cancer research, you need all these different type of data sources and data qualities, basic demographic information of the patient, but then also genomic data, diagnostics code, what kind of procedures have been made, lab tests, imaging results, and so forth. So basically the key here is that you need to connect to all of the data sources, but also you need to transform the data in a format that you can actually use it and utilize it efficiently. So regarding the high security data analytics platform, so why was this developed, these workspaces? We have a very strict secondary use of healthcare data law that is being applied now here in Finland, and this is from a data research driven initiative, and the goal is to create this kind of competitive, attractive environment with enough computational power, like GPU power, to process masses of information and advanced and the most modern tooling, but also very high security demands. We had a pretty tight schedule, and this needs to be up and running now in few months. So this was quite a challenging development project for both parties. So the regulation here, just the basics here, is that this is like I said, very strict one. No direct internet connections allowed to the workspaces, and we need to have all this authentication and user access needs to be very tightly controlled. There's security assessments and different types of security requirements from the government, but also we need to have certificates from the external security auditors. So how do we implement high security in this environment? First of all, there's two-step authentication. There's isolations of these research workspaces through virtualization and network isolation and other kind of methods like resource slicing. very comprehensive logging and audit trailing and active monitoring of the security monitoring of the environment. And also outside of the, let's say, the technological solution, there's a lot of emphasis on the data management processes and governance of the environment, and also the premises security and personal security. So all the persons accessing the data has been cleared by the Finnish intelligence services and so forth. So very strict requirements for the environment, and this is what it looks like. So you have different kinds of virtual environments or workspaces that the researchers can access. You have a Windows environment with two different configurations. One is more basic, one is for the high performance computing, and then for the Linux side you have even more options, with the imaging and genomics having their own special environments. But what this offers is that you have the scalability from the cloud. You can have more or less power for the computing as needed. You can select the category of the workspace that matches your need. And then the researchers, they have all the latest tools there available that they can use for their research without having to manage the environment themselves. And this is the last slide. This is just an overall picture, and that shows that how this whole environment and whole data management process works. So we have researchers that can access this service portal through a web browser with the multi-factor authentication. So previously they had to use the VPN connections and different software clients and so forth to access their research environment. Now it's just through the web browser, which is simplifies things. So in the service portal, the researchers can then select that what kind of environment they would like to use, and from there the process goes that then the data transfer and access, which is controlled by HUS. They will provide the data to the workspace through their audited service delivery. So you have dedicated persons there who control the data transfer according to the research permits, and also manage these quarantine environments for the external data and so forth. And what we do here, our role in this environment is to provide the technical management and further development of this solution. So we also have high security audited service delivery from the dedicated personnel that who manage this environment and the tooling and do the monitoring and all this for the service. But this is about it. Hopefully this gives you a glimpse of how to implement a very high security, basically a military grade security environment, managing for the management and analysis of healthcare data in the hyperscale cloud. Thank you.
Thank you so much, Joona, for this presentation. It's an amazing system, and I'm sure it's been plenty of work getting to this. We have a lot of questions for you, Mikko, and I just want to check, Mikko, can you hear us now, and can we hear you? No. Well, okay. So Mikko, if you get on the line, just shout out so we know you're there. A short question then for you, Joona, that came up, and that is, when you talked about, of course, the strict regulations, and that is, of course, an absolute requirement. To what extent were the legal requirements already there, and what kind of adaptations have you had to do together with the authorities, if any, to make this work?
Yeah, of course, since this has been a this has been a new law and a new regulation in Finland. So there has been a very, let's say, wide and deep discussion between the different stakeholders, meaning the government and the healthcare service provider and different technology vendors and other stakeholders who use the data. So it has been a long process and long dialogue with a lot of adjustments going forward. But I think it's just that from an implementation point of view and technical point of view or solution point of view, it's just that the requirements are so strict that actually to implement a solution that is compliant with the requirements, that is quite difficult to do and very complex as a technical solution, because you have all these moving parts and a lot of automation is required and so forth to really to be able to fulfill the requirements in a cost-effective way. And I think that has been the biggest challenge here, that how do we manage this very complex environment in an efficient way.
A quick follow-up question on that, and that is, to what extent do you believe that the issues that you faced and those discussions have been specific to Finland, or are there learnings, a lot of learnings also on the regulatory and legal side that other countries can benefit from? And have you already even started those discussions with other countries?
Yeah, I don't think there's anything really like country specific or market specific here. It's just this is the, let's say, one way of implementing a very high security environment. So that I think mostly what we are doing is just following the best practices in how to provide an environment with high security, not just from a technical solution level, but also you need to really emphasize the managed services and the services around the technical solutions also, that because the security of the whole solution is as strong as the weakest link here. And usually us humans are the weakest link, so we need to pay attention to also the governance model and how people work and what kind of tools they use.
Thank you so much. So with that, I would like to introduce the whole panel. So please stay on, Jona and Mikko, if you're there. Also Marcus, but first of all, we also have Mats Sundgren, who works at AstraZeneca with health informatics, and we also have Helene Seeman-Lodding, who works with the same topics, but on the public side. So Helene and Mats, welcome on board to the panel discussion as well. And I would like to start with you, Mats. You work at AstraZeneca, and as a large pharmaceutical company, I would like to ask you, could you name maybe a few examples of how AstraZeneca is using health data to support research in clinical trials?
Absolutely, and thank you for having me today. I just want to say that the kind of reusing health data in a trustworthy way is exciting. I think the technology is there, the quality is there, but one of my interests over the last 10 years is to find how we can use patient data, health data in a scalable way for support clinical research and clinical operations. And I think that's still a challenge, although because, so what we are doing right now, which is important, is that we can use large scale de-identified EHR data across 20 countries right now in a real-time fashion. And we can do that to have an impact to get our clinical designs and our hypothesis right in the first place. So we have a sort of a suite of impact services where we could actually deep analysis of understanding the patient population. For that purpose, we don't need really real-time data, but it gives us an understanding how we can design the protocol. Next step is we can validate our protocol with health data. from multiple regions, that is across countries, very impactful. So we get the protocol right in the first place. Second, we can use platforms across multiple countries to do the feasibility. Feasibility in the industry and the academics today, I argue, takes months. We can do this before lunch. And we can also, depending on the vendors and the networks, also check ourselves where the eligible patient resides in the different hospitals. So it is very important for us. And yes, say it is the recruitment aspect of large randomized clinical trials is so important for us and clinical research to be effective. And that is to say that we need to understand where the patients are, right? So we can run our trials with fewer sites and getting the trials much faster. So, which means, and I will stop there, that we're also looking forward to do the capture of data much more efficient. In other words, that we are, looking for solutions where we can capture data directly from the electronic health record system into the clinical trials. I stop there.
Thank you, Martin, and good point. So back to you, both to Jona, Mikko, and to Marcus. To what extent have you made your records and all the data collection that you're doing today? Is that open? Is it possible for companies like AstraZeneca and other commercial researchers to access the data that you're collecting in the system? Maybe Marcus, if we start with you.
We have a large number of collaborations with different private enterprises, including Astra, and we make the data available through a intermediary, actually, to reach this level of security that Jona mentioned, and which is super important. So, but we have a number of research, primarily research initiatives going on real world data in Hallands, together with the local university, where we started a group, a department for this purpose specifically, and that's not only it's directed towards all of the life science sector, including the pharmaceutical industry, but also the medtech industry, in order to understand the product's possibilities in a real world healthcare system.
Thank you. And Mikko or Jona, same question for you. So we've seen the technical parts of the solution. So really, what is the next step? And there was also a question in the panel on that same topic. So to make this accessible and use and the utility for healthcare, not from a pure tech perspective. Are you working with both public and private researchers?
See if Mikko's there. If not, I can comment. So in HUS we have a pretty vibrant ecosystem, research and innovation ecosystem called Clever Health Network, which is coordinated by HUS. But in this multi-vendor ecosystem, you have academia, you have the care providers, and then you have companies from different industries. You have technological companies like us, Microsoft. You have medical company, medtech companies like GE and Siemens, local startups, and then also these big pharma companies like Roche and Takeda. And what happens in the ecosystem, in this data-driven ecosystem, is that basically the data platform acts as a common workspace with the data and the tooling, and then these different groups and projects, they can build their or run their research and build their new solutions and innovations in this joint workspace. So do both research, but also really especially in some of these projects, the aim is to develop a new commercial solution for the market.
Thank you, Jona. And Helene Seman-Lodding, you work at the region Västra Götaland and at Helsingfors University Hospital. So what is your view? Do people in general, how do they feel about us collecting their personal data and collecting it, sort of using it for as in a big data setting? Do you have any comments or thoughts on that topic?
Well, as a clinician, I think people in general likes to share. I don't think the obstacle is us, everybody of us. We're all patients. The obstacle is not our willing of sharing data. I think the obstacle lays on different levels, and we have to mitigate them with different tools and methods, as I think the previous speakers nicely described. As a representative from the public, I would like to emphasize a couple of reflections on the presentations. I think Magnus showed very nicely that we have difficulties in creating new working flows, depending on that we need other competences in the room that we're not used to. We need to work cross-professional. And I think Magnus also showed very nicely that there are enormous amount of data out there, but we have difficulties to really use them. Sweden has a long history of building quality registries. And I'm not surprised, Magnus. I've been on the board on 2 quality registries for a long time, and I've been looking at the Sweetheart registry and the way that this registry has turned in data to real hands-on information for the clinicians to use out there. I think we have to spread the news, show good examples, as you do in Halland. But if I look at Jonas' picture, in my other part, I work with that both Mats and you all emphasize that we have to work on how we put data into the records, how we make data collections, that people are aware of, that we can use data and information in a much more constructive way and just using them as a written letter. And to do that, we need to build knowledge, make people aware of, and also have the knowledge. Why do we work with data structure, standardization, and create the prerequisites for this development? And finally, don't forget we need tools to validate and evaluate that the solutions that we put forward, the new information we get, is it really that effective as we think?
Thank you, Helene, and that to all of you working in the great member companies. I hope you heard Helene saying here that we need more tools to evaluate the usefulness. But Helene, a second question for you. So I think it's great when Marcus, when you talk about the very concrete results that you've been able to show, both in terms of the cost saving part, which we know is one of the biggest issues in healthcare. How can we work? You both work in a Marcus, you in a semi-clinical setting, and Helene, you working in a clinical setting. How can we ensure that those different groups that we're communicating to, the payer groups and the caregiver groups, that doesn't necessarily have that close connection, that they see these benefits together? Is there any work that can be done there to make it more useful? And I'll start with you, Helene.
Well, I think we can. First of all, we have don't forget the universities and the schools where we educate our students, and we have a unique possibility to actually put this cross-professional perspective early on in education, so that we let students from different programs, but that are going to work in the healthcare sector in the future, actually share common parts of the programs together. So we need to create a knowledge. Then we need to build infrastructure, and legislation is one, but it's also to make computer resources available for the researchers, which I think Jonna nicely showed, how the researchers have a infrastructure so that you can actually get that you can have all this data. And you need support as a single researcher. I'm a researcher and responsible for research programs at Sahlgrenska. It's very difficult to have all this knowledge on a few hands.
Marcus, any comments from you on how we can ensure that the clinical and payer department, so to say, understand?
Well, the educational perspective is certainly true, but it's a long-term perspective, so that will take time. What we did was to inform and integrate the junior and mid-level management in our healthcare system early on, and once you get used to getting the information you need to make good decisions, you never want to go back. So that's having them on the journey from the beginning is important, and also internal education, like AI is still something that is very scary in the ears of many, but it's becoming now a natural part of analytics in-house. So it's a gradual evolution. We will get there. We are getting there, but it will take some time. But there will be a few forerunners that is always in the front, and you need to let them run because they are the ones pulling the university hospital behind them. So and inspiring and educating and being good ambassadors. So it's a multifactorial task to move a grand organization.
Helene here. I really liked your concept of jam sessions.
Good. Time is running out. It's a topic that we could probably spend several hours discussing. There has been discussion going on as well in the chat. So if we haven't answered your questions, see if the answer is actually already in the chat, because I know all of the speakers have been in there. What I would like to just end up with, it'll take one more minute, is I know you've all been talking about courage, and you've also been talking about perseverance and persistence. But if there is one ask that you could give to those listening today, one ask that will make a difference for how we utilize health informatics in the future, and I will take it around the table, what would that be? And I'm just asking for a short sentence, not a full answer. So I will start with you, Mats. I'm sorry to call you out here. What's the biggest ask?
My biggest ask is that all the promising progress is thinking about scalability and interoperability of structured health data. Because I argue that the structured data as it resides in terminologies in the different EHR system is still going to be the gold standard for the next 10 years. That is the fastest route for improving clinical research and clinical operation across countries. So continue to improve, but think about the federated aspect of using services. Of course, those services should be GDPR compliant.
Yeah,
that's my answer.
Yeah, I think my opinion here is quite clear, and this is a message for the whole of Sweden that you need to go to the cloud, and that's it. the gap between the on-premise solutions and cloud, it keeps increasing all the time, and the futures in the hyperscale platform.
The cloud, here we
Yes.
come. So Helene.
Yes, we can't afford not to solve these challenges. And the good news is that I think we've seen increasing examples of the benefit of walking this road. And I noticed there was a question about emerging health threats as COVID-19. I'd say this pandemic has opened our eyes. And as an intensive care doctor, I've never worked during a condition where we shared data in a way that we did during this pandemic. So
I think there are a lot that can confirm that. So Marcus, from you finally.
I would say start listening to people that you don't usually talk with and understand what they're saying. So clinicians need to understand what data scientists are actually saying. And data scientists needs to listen to and understand what legal teams are actually saying. We're all working for the best of the patients to have them get longer lives and more healthier lives. But we need to understand the competencies that are spread across different professions. We all often try to solve problems ourselves from our perspective. This is eclectic thinking. So training your eclectic thinking is the key to going forward. If you don't do that, don't bother coming to Halland at least.
Thank you so much, everyone. There were some really good learnings in there, and I hear you loud and clear. We can't afford not to be patient-centric, and therefore we can't afford not to utilize data when it's there. So with that, I hand back over to Stefan. Thank you all the speakers and everyone who's been listening and being active on the chat.
Yes, thank you, Mia. Thank you all the speakers. Just summarize, I will let you go quite soon. We have recorded the whole session, and it will be published in Great's website within a few days. We need to work with it a little bit, but it will be there and you will get an email as you have signed up for the event. So once again, thank you all speakers and participants, and I wish you a great day. Thank you.